My dear friends and the esteemed audience who have joined this program to listen about the diabetes in India, the peculiarity, the specialities, the atypical features, typical features. And I think it's one of the most appropriate thing to happen while we are discussing in the time of in of celebration of the 75th year of India's independence. You know, it is Azadi Ka Amrit Mahotsav, and we must discuss about India, our motherland, very often. Now, to make a long story short, I would like to mention that India is a country unique in the globe. And diabetes is one of the most important contemporary challenge the world over. Now, it has been said diabetes is the major global health problem, affecting about 537 million people and leading to over 4 million deaths per year. And this 4 million death worldwide is a very high mortality range. Now, several prevalence that has been done in our study suggest that the burden of diabetes in India is advancing faster. At the first survey by Professor Ahuja, Tripathi et al. Was about 2 to 4%. Today it is at the minimally it's about 9.75%. Therefore, also in the all LMIC, low and middle income countries, the prevalence of diabetes is increasing, and India is no exception. And it has been said that 1 in 17 people in India, 1 in 6 people in India, that is about 17% of the diabetics are from India. 17% people are from the India, and you see that we had a famous uh, ICMR in-depth study, and looking at the diabetes in the 20 to 79 years of age, it has been reported that approximately 9.6%. To make it simple, at least 10% people in 2021 have diabetics, and the number is going to double to 124 million. Today we have 71 million. It will double to 124 million in 2045. Now, being at the epicenter of diabetes, why Indians are getting it? Indians are not obese. Indians have a low BMI distribution, and they have even low overall life expectancy. And diabetes is a function of the elderly. We have a low life expectancy. So why we are different from the Western diabetes counterparts, and why do we show a higher propensity to diabetes than our Western counterparts? And we develop diabetes, my dear friends, at a younger age. ICMR in-depth study showed that we take off diabetes at the age between 39, sometime at the 29. We develop diabetes much younger age, and we have a much lower BMI. Does the environment responsible for that? What is the significance of the various factors in our different epidemiological profile, and also the management profile of our diabetic patients? Dear friend, it's my great pleasure and honor to welcome the guest of honor, the expert of honor for this program today, no less a person than our very, very dear friend, Professor Dr. Hemant Thakur. Hemant Thakur is a very prominent physician from the city of Mumbai. He is one of the top key opinion leaders of the country, and he has a huge clinical experience. You name a hospital, Bridge Candy, just look, any hospital in Bombay, he's a consultant diabetologist there, and he has kept the flag of India flying high, not only in India, but the international forum. And one of the education has been one of his passion in various TV programs that you must have seen, and the various forums wherever he has made an impact in the teaching of diabetes in India. Therefore, over to Hemant, my dear friend, to make his initial presentations regarding this topic. Hemant, all is yours.
Thank you, Dr. Das. Dear viewers, it's a proud moment for Dr. Das and me to be on this IJCP platform today. 75 years ago, our proud country got its independence. And on this occasion, for the two of us to interact, it's a very heady, glorious time for us. The biggest problems that we are finding with India is the unfortunate health issue of early diabetes, early hypertension. early coronary artery disease. So I'm so much fueled today by Prime Minister Modi's pledge that he has sounded from the Red Fort, that health should be one of the most important, one of the top of the five criteria that he has promised and he has pledged to give this nation, so that in the next decade, India will shrug off this tag of having a capital of diabetes, a high incidence of coronary artery disease, and a lot of genetic induced lifestyle nurtured problems. I think with that as our theme, I'll be happy to present some slides, and maybe Dr. A.K. Das would like to start asking any questions. Dr. Das, would you like to think and see how the Indian diabetic patients are different? I want
Yeah,
to show all my colleagues today, yes, there are physiological differences between Indians and Westerners, and they've been dubbed as major factors to the prevalence of higher prevalence of diabetes in this country. If you see in my next slide, Southeast Asia and Asian Indians are characterized by a decade of early arrival. Indians and Southeast Asians get diabetes much earlier than the West. And the problem is that we are thin, fat Indians. Our BMI is lower, but our paunch is larger. There is greater abdominal obesity. The apple is around us. The pear is with the West and the apple is with the East. In the West, they have more of hip and thighs. We have more of apple with the middle. And this middle is where insulin resistance comes in. So, Dr. Das's first question, which he said, why is diabetes commoner amongst Indians and Southeast Asians? And this is the prominent reason. The middle that we have generates great insulin resistance. And this insulin resistance results in, or is a result of, an early decline in beta cell function.
I
As
think
a
that was the
result of which,
first question, Hemant, is that in spite of having undernutrition, in spite of having lower BMI, why should we be dubbed as the diabetic capital of the world? But beautifully, you have shown it is the onset at a much younger age, so number increases very fast. Number two, the treasure in the tummy, the visceral obesity, the fat in the abdomen, and also higher insulin resistance and the beta cell function declining very early. As you said, 10 years, 1 decade earlier than the Western counterpart, are the major reasons why you have more number of diabetics. Do you feel, Hemant, that the westernization has played any role? We call it acculturation, coca-colaization, migration, internal migration from village to the cities or metros, or we migrating to other countries in the world. Migration, coca-colaization, westernization, has it played any role in the increased prevalence of type 2 diabetes in our country, Hemant?
you're absolutely right, sir. Right from the bell bottoms to the jeans to the mini skirts to the Microsofts and the Macrosofts, we have imbibed everything. McDonald's is everywhere. French fries are everywhere. Robust carbohydrate drinks are everywhere. Urbanization of our cities with even percolation into the periphery is everywhere. Western culture has invaded our minds, our societies, our thinking, and unfortunately found a place to nurture our ill fated genes, which we are now presenting with diabetes. You know, you and I have worked together and are working in the pre diabetes campaign. I'd like to share a small thought on this. An American who is pre diabetic, which means 6.4 or 6.1 and less, depending on ADA or WHO criteria. He will take 7 to 10 years before he becomes a diabetic. So the evolution is slow. By the same token, the Indian who is pre diabetic metamorphoses in 1 to 2 years and becomes a frank diabetic. This Western diet with refined carbohydrates, processed foods, and trans fats. This Western motorcycle and car culture has made us sedentary. We don't walk. Now we have to adapt the Western newness, the bicycles, the walking tracks. It's time all that we have to see. And if we don't do that, we are going to be in trouble
Yes,
because the
I think
changes in our habits, the availability of sweet cuisines, and then, of course, social stress.
I
The
think Hemant,
social stress is
Hemant,
very
I
high.
think I will like to emphasize the point in a single sentence. You know, many of our countrymen, including our own relatives, cousins, we sometimes denounce the Indian diet and we adopt the Western diet. You know, people think that the Indian diet is insufficient, it is not sufficient, is not adequate, and we go for the Western diet. And that's the greatest mistake. You know, the Indian diet consisting of a high fiber diet, consisting of the diet of a good number of vegetables in addition to whatever non-vegetarian food we take, and you know, it's a balanced diet, which is a very important aspect of our country's culture. And this diet, which is a very diet, rice, dal, chapati, good amount of sabji, and you know, curd, these are the things are very important. But aping the West, as you rightly pointed out, going after the fast food, I have coined a term: fast food kills fast. And you know, you rightly pointed out, in India, because of these things, the pre diabetics convert to full blown diabetic in 1 to 2 years, rightly pointed out. Whereas elsewhere in the country, the conversion rate is much lower. So, therefore, what you said is absolutely correct. The thinking that our diet is insufficient, our diet is harmful, our diet does not have the all the components, the balanced diet together, is not true. Indian diets, I can say, people are becoming more and more fond of Indian diets. That you rightly said that, and we are changing. And then also they pointed out the walking, the exercises, the physical activity, the getting freedom to sedentarism. That's very important. Now, I just like to know one thing, that what do you think that the prescribed medications that we have today for diabetics are the adjunct to the diets of an adult? Am I correct? Especially Indian diet, if the if the person develops diabetes, the drugs that we prescribe are adjunct to the diet, and diet plays a very central role in the management of diabetes. What do you think?
I think this last paragraph of thought which you just gave us, the perception of diabetes in this country needs to change. This country needs to know that they are susceptible. This country needs to know that they have to use their feet and not their tongues. And this country
Absolutely.
needs to know that their forefathers, Indians, our grandfathers, had their teeth, had their bones, had their activities till the age of 75, 80 plus, because they eat healthy. They did eat healthy. Now, with this perception being a little distant, we as caregivers have to play a very important role in dispensing thought, advice, and medication. We have already discussed how we can give them counseling regarding lifestyle. But lifestyle usually does not work and is short lived. By the time the patient comes to us, his HbA1c, because of beta cell steep decline, is already more than 1.5 above upper limit of normal. Is 8 plus, 8.5 plus. Now, here is where I want to differ with the guidelines. You know, the term guidelines needs to become renamed as recommendations, because
Absolutely
what
correct.
is because what is food for the goose is not food for the gander. You have to tailor the requirement of medication according to the patient and according to the area where you are. If you have this podgy fellow with a BMI of 26 and an abdominal girth which is 105 centimeters, if he comes in with an 8.7 HbA1c, and if you follow the guidelines and you begin with metformin, and when that doesn't work, you begin with something else, no, you don't want to do that. You have to now use your mind as to what you want to do. And that's where the newer therapies come in. I'm
Hemant, I
so
think that's a
happy.
very, yeah, that's a very important issue, Hemant. You know, what we are discussing today is early aggressive control. The first year control matters. The sequential therapy is not what we're aiming at. Absolutely correct. Hemant, at this stage, I would like to go through your presentations. Then we'll come back. Whatever not discussed in the presentation, we'll come back to it. Can I have your
That's a
third slide
brilliant,
onwards?
I
Go
think that's
through.
a
Yeah.
brilliant way
Yeah.
of doing
You can
it.
move the next slide, next slide, next slide.
So we've talked about the Asian Indian phenotype, uniquely characterized for cardiometabolic risk, the visceral obesity, the lower metabolic resistance but higher insulin resistance, and therefore increased cardiometabolic, cardiorenal risk. We have to think of personalized approach relevant to the unmet needs, and that should be the underlying principle. Next slide, please. We've talked about the lifestyle changes. We need to look at the changes in our habits. We used to farm and we used to walk. We used to shun processed foods. Today, sweet cuisines, chocolates, fatty burgers, all the cookies, everything is available. And of course, unfortunately, this digital world has made us very stressed. Sitting at home, you're in 4 continents and 6 offices, and you want to deliver your best at each place. You're feeling sleepy because New York markets began early and Japan markets are just beginning to close. And then you want to have more coffee, you want to have biscuits, and therefore you have forgotten your perception of diabetes. Next slide, please. So, what are the challenges posed by type 2 diabetes in India? There is a rising prevalence in urban and rural areas. It's the younger people. It's the higher prevalence of prediabetes. It's the delayed diagnosis. All this working on genetic and environmental risk factors. Low disease awareness amongst the people and limited healthcare facilities. Today, our Prime Minister has pledged to help the country, and we want to strengthen his arm. There is a high cost of disease management, but if we begin early, there'll be lesser complications. So the rising rate of diabetes complications can be nipped in the bud, provided you give the right treatment early enough. As Dr. Das said earlier on in the show, you have to have aggressive treatment, aggressive, thoughtful, individually tailored treatment. So, this suboptimal diabetes control clinical inertia has to be shrugged off. You have to put your mouth where the disease and your action is so that your pen flows through your thought mind and your prescription is correct and apt for the patient. Next slide, please. So, how do you manage the diabetic Indian patient? Be proactive, be positive, and be open, forthright with the patient. Do not play around कि हम पहले ये गोली देंगे, फिर ये नहीं चलेगा तो दूसरी देंगे. We don't treat to fail, that if A doesn't succeed, we'll add B, and if both don't succeed, we'll have C, because that breeds suboptimal glycemic control, which increases the risk for micro and macrovascular complications. If you tailor the patient early his therapy, and if you use the right combination, depending on what the patient has, if the patient has a paunch, he has probably hypertension already coming in, then multiple drop combinations are available which can manage the various pathophysiological problems.
We have DPP4 inhibitors and Sglt2 inhibitors. And if you put the two together, you can target out of the octet almost all the several pathophysiological defects in the type 2 diabetic patient. Let's have the next slide, please. See where they work. SGLT2 inhibitors and DPP4, if you combine them, they are a pertinent partner to metformin in providing meaningful glycemic control. They improve the metabolic profile of the patients, and they are preferred for patients with a higher predisposition to cardiovascular events and kidney disease. And in fact, if you use this combination early enough, especially in patients presenting with HbA1c levels of more than 1.5, you can prevent cardiovascular problems creeping. You can reduce body weight. You can see that if you properly guide them without the risk of UTI and without the biggest risk of hypoglycemia, you can provide safe and cost effective glycemic control. Because when you treat, you have to look at what else the patient has. When you treat, you have to prevent hypoglycemia so the patient doesn't get frightened. So you have to take two partners. Even if you have to marry these two drugs early on in the disease, sometimes even before metformin, if you want to be aggressive, you can go ahead and do that. Let's see the next slide, please. If you see this suitable option, SGLT2 inhibitors, and our government has been very nice. We've brought down the prices of SGLT2 inhibitors. So if you combine it with DPP4, there is safer, rapid, and sustained glycemic control. This is not a fly-by-night. You have to sustain the glycemic control so the HbA1c remains ironed out. It helps and controls and improves insulin resistance and saves the beta cells. It drops weight. Dropping weight is the most important challenge, the biggest stumbling block. And you know, the extra glycemic effects of these two put together is the reduction on blood pressure. And both of them put together are cardiovascular friendly, in fact, cardiovascular beneficial. It definitely reduces the pill burdens, so the compliance improves. And overall cost effective. You know, the pill may be a little expensive to begin with in your mind, but if you take that pill, then you have no complications. If you take a made in China phone, which gives you everything that a good other phone gives you, and you say it's cheap, after 6 months, you'll have to buy the second piece. And after 12 months, the third piece. So 3 of these simple, cheap phones is equal to the cost of one phone that you bought early, which will last you longer. So SGLT2 DPP4 in the Indian context with big paunch, short, thin, fat Indian with likelihood of cardiovascular complications, not able to reduce weight, bothered by too many pills, rapid, sustained, and safe. I think if there are any more slides, we can discuss later because Dr. Das's comments would be important here.
I think, Hemant, your points are very well described. I want the audience to take home these points, that we have increased prevalence of diabetes. You rightly pointed it out, and increasing from 2 to 4% to almost 10% to 13 to 14%. At the same time, we must remember we have higher prevalence of pre-diabetes, which is more than the diabetes. Am I correct, Hemant? It is
Yeah,
10%
absolutely.
diabetes, 14%
Absolutely.
pre-diabetes, and they are waiting to become diabetic. So we have to take care of them. Third point you said, that the genetics can load the gun, but the environment which triggers the gun. If you take care of the environment, take care of the drugs that we give them, take care of their diet, the medication that we want to give them, we can change the scenario. Dear friends, as you rightly said, we have a drug in our country, all the world over, but especially in India, it's the DP4 inhibitors. Hemant, I'll hasten to add that it has been shown that the DP4 inhibitors are much more beneficial in the Indian population than the population elsewhere. And the reason is very simple. because of the high carbohydrate diet we have, and the way we take care of our issues that we have. I'll give an example. Like, that we have in India, while the onset of diabetes, the 50% beta cells are lost. And by the time they come to us, it has been said 67% beta cells are lost. Am I correct, Hemant? So we have a
Absolutely.
drug in our armamentarium, DP4 inhibitor. Now, this DPP4 inhibitor acts through a mechanism other than the beta cells. Am I correct? It's a glucagon arm which comes into play. And no, Sgl2 inhibitors are a drug which have got four important properties, as you rightly pointed out. Number one, glycemic efficacy. Number two, the cardiovascular health friendly. Number three, the diabetic renal disease friendly. And number four, a survival benefit. So what more you want? They also work on the most important, the non-alcoholic fatty liver disease. So SGLT2 inhibitor taking care of the glycemic efficacy, that is bringing down the HbA1c. Number two, taking care of the cardiovascular health, like most appropriate drug when there is a severe risk factor burden or there is a heart failure. Number two, they are the people, many trials which have shown that they protect the person from the kidney disease for a very long time. And some of these things, some of the molecules also have shown survival benefit, and I believe the class effect is also applied to the drugs we have in the armamentarium. And they take care of the non-alcoholic fatty liver disease. And we did not have enough drug in armamentarium which can take care of our weight. And I call SGLT2 inhibitor as the nutritional offloaders. Like you offload the diabetic food, we take any amount of food, it takes away in the urine. The weight loss can sometimes be up to zero point 0.5 to 2.5 to 3 kgs. You know the benefit of that. Therefore, a combination of SGLT2 inhibitor and DP4 inhibitor, which acts the glucagon arm, as you rightly said, even prophetic Hemant, it addresses 7 of the 8 of the ominous octet. The second issue I like to point out that our country is a land of fixed drug combination. The fixed drug combination have three advantages that I always speak about. They are very convenient to take because the pill burden comes down. Number two, the compliance increases. And believe me, the cost also comes down. And you rightly pointed out, today these drugs have become A. They have become very affordable. The price has come down to a level where every Indian can possibly buy this drug. Number two, they're appropriateness. Both of us have shown very clearly they're appropriate for the Indian diabetics. Number two, they're available and accessible in every part of the country. Therefore, this combination is poised to become one of the greatest combination for the care of the diabetics. You may ask me, how do they compare to metformin combination with the SGL2? The latter one, SGLT2 per metformin, is also a good combination. But the benefits that you have DP4 inhibitor, the glucagon-centric benefits are not there. At this point, I would like to ask you one point, that what would you like to say regarding the use of SGLT2 in the rural areas, BP4 in the rural areas? I mean, you must also address this to the people who are not in the metro, non-metro, tier 2, tier 3 cities and beyond. How do you see this drug? I'm asking three things, Hemant. One is the safety. I think they're very safe. You have to justify that. I say that they are the drugs like Indian petroleum advertisement. Fill up and forget. You give the drug, you are not worried about sulfonylurea and da, 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 da. I would like to listen from the horse's mouth about their safety, about the adaptability in the Indian household in the rural areas, and how they can do the job.
So, if the rural areas have so much of percolation of westernization, they too are suffering from obesity. They are having issues of cardiovascular problems. Diabetes and hypertension have a fatal attraction. One attracts the other. So you rarely find a diabetic who within 5 years doesn't become hypertensive. Now, even in rural areas, though they do a little more walking or a lot more walking, we hope they do that. they still have cardiovascular risk problems. Uncontrolled diabetics have renal problems coming up. And they also have, now the term NAFLD has been replaced by a term called MALD, metabolically altered liver disease. So this conundrum of metabolic syndrome, even in rural areas, exists, maybe albeit to a smaller extent. So here, if you use the petroleum slogan, fill up and forget, prescribe and forget, at least you will not be burdened by the problem of having issues of hypoglycemia. And this hypoglycemia is something which frightens the patient. So if the rural person doesn't get hypoglycemia with this combination, I also